and the objectives are for you to describe what is shedding, describe the molecular aspects of shedding, it's very important, and to discuss the clinical applications of both the tooth eruption and shedding. See, all the basic subjects which you're learning, of course, it is very important for you to understand the basic foundational knowledge. But ultimately, you're going to be a clinician. So why are we studying this? You have to know that. Otherwise, you will never pay attention to whatever you're studying in your basic subjects. Okay, so we have to discuss after every lecture, what are the clinical applications? What is the message that you're taking from today's presentation, and apply it when you're treating the patients, okay? So if we talk about a definition of shedding, it can be described as a physiologic process. So there are two types of processes in the body, physiologic and pathologic. Physiologic meaning it is normal, like it is a physiological phenomena. It is not abnormal. When it is abnormal, it is called as pathologic. Okay, so this is a physiologic process resulting in complete elimination of deciduous dentition. How many sets of teeth does humans have? Primary and permanent. So all the deciduous dentition has to fall for your permanent tooth to stay in the oral cavity, erupt and continue to stay. And how does shedding happen? Shedding is a result of a resorption. Do you know what is the meaning of resorption? Removal of that structure, okay? So it's the progressive resorption of the roots of deciduous teeth and its supporting structures. So in this case, it's not the alveolar bone as such, not the supporting bone, but it's the periodontal ligament and the cementum, which will be resorbed as a process of shedding, okay? Okay, so I told you we're talking about the resorption of the deciduous molars now, okay? So initially the pressure is lingual to the primary tooth. As you can see here, this is the permanent tooth germ of the deciduous molar, and this is the primary tooth which is erupted into the oral cavity. So initially it applies pressure on the lingual surface, but eventually they come to lie between the roots of the primary tooth. Okay, so the permanent tooth germ comes directly underneath the primary tooth germ, directly apical, you can say, and it starts resorbing the roots of the primary tooth. Until when? When do you think the resorption will continue? Until the deciduous tooth is shed, and then the permanent tooth can erupt into the oral cavity. So this is the shedding process. And the same thing happens in the incisors as well, but the difference is, you know, that the permanent toothbud of incisor is situated lingual to the primary. So the eruption pathway by the gubernacular canal, if you remember the skull which I had shown you, it is lingual. So it causes the resorption on the lingual surface of the root until the tooth is lost, and then the permanent tooth replaces its position in the occlusal cavity. Okay, so these are all like different phases. How it was at the same level, then it becomes, then it lies at the apical 1/3 of the roots of the primary teeth, and then it causes the resorption and eventually erupts into the oral cavity. So the resorption occurs on the hard structures, of course. This is both on cementum and dentin, because we're talking about the root of the primary tooth. So there is no enamel in this scene. It is the cementum and dentin. And it removes both the organic and inorganic content. All this resorption, which we were talking about, happens by osteoclast, and it is characterized by the presence of the osteoclast. And there are some other cells which I will discuss with you when I move to the histology. So let's see what are the molecular aspects. So just now I told you that dental follicle has a very, very important role, and the whole process of resorption is actually initiated by the dental follicle, and it is also regulated by stellate reticulum. So basically they are like star-shaped network, okay? The reticulum is a name for the network. So the cells are all connected to each other by the cell junctions, and they're stretched apart to look like stars, and that's why they're called as stellate reticulum. So these two have a very important role when it comes to shedding. They secrete certain molecules called cytokines and some transcription factors, which is what initiates the whole cascade of phenomena. So dental follicle is in a very nice position. So the tooth is finished forming, all right? So the layers which was around it collapses into just 2 to 3 thickness layer of epithelium, okay, of flattened cells. That is called as reduced enamel epithelium or dental follicle. Okay, so that dental follicle protects the tooth until it erupts into the oral cavity. Okay, so that is why I said it is placed in a very strategic position. So this is the dental follicle of the permanent tooth. So it is very easy for it to release factors to cause resorption of the primary tooth which is present above it. Okay, and what it does is very similar to pathological processes, like whenever there is any tumor, whenever there is any kind of carcinoma, it applies pressure, and the same receptor ligand system called as RANK or RANKL, the full form is receptor activator of nuclear factor kappa beta. You don't have to know the full form, don't worry. Don't stop breathing, breathe, okay? So just remember it is RANK or RANKL. It's a ligand system which causes the resorption in pathology, and the same factors are activated even during this physiologic process of shedding, okay? And that happens by the dental follicle. That's why it has a very important role. So whatever we read till now was about the primary root resorption with the permanent successor, but there are also cases where there was the root resorption without any permanent successor. So they say that it's not necessary that the permanent successor is a prerequisite for this process to occur. So whether there is, sometimes there's developmental anomaly and the permanent successor might just be absent, but still there is resorption and shedding of the primary teeth. Okay, so that was one of the theories they said. So when I said I will discuss with you the osteoclasts, which are nothing but the bone resorbing cells, okay, we also have similar cells called odontoclasts. Odonto is relating to the tooth, odonto, and clasts are the cells which cause the resorption. So we have cementoclasts and dentinoclasts. What are cementoclasts? Causes resorption of cementum, and dentinoclasts causing resorption of the dentin. So what we see here, the multinucleated giant cell next to the dentin, is nothing but the odontoclast, okay? So let's see what are these osteoclasts. Osteoclasts are derivatives of monocytes or macrophages, okay? So they are from the lineage of monocyte and macrophage. First, they form the osteocyte precursor, and eventually they form these giant cells which have multiple nuclei, and that's why they're called as multinucleated giant cells, and it could be between 4 to 20 in number. So what these osteoclasts do is they remove the inorganic content of the hard structure they're associated with, as well as the collagen matrix. Okay, it's not just the mineral component, also the protein matrix is removed by using the hydrolytic enzyme. So it's these ruffled borders or villi which actually increases the surface area of the osteoclast and causes more resorption. So there are some differences again when it comes to the resorption. So this single-rooted teeth doesn't wait to shed until the entire root is resorbed. It can even like halfway through, it can just fall, okay? And most of the coronal pulp is intact, if you can see here, okay? And the resorption has not even reached the crown, and the tooth has been shed off. Whereas in case of molars, the root has to be completely resorbed and the crown will be partially resorbed when the primary tooth sheds. So this is another important difference between anteriors and posteriors. So, whenever anything happens in the body tries to defend itself. Okay, so the bone and tooth are all structures of the body. So, when it is undergoing resorption, the body tries to do certain amount of repair. Okay, but of course, the resorption takes over. There is a tip in the balance, so the resorption overtakes, and the repair doesn't proceed to the full extent. So repair is achieved by cells which resembles a cementoblast. Cementoblasts are the cells which form the cement, and the final repair tissue. That is the reason why it resembles cellular cementum. But the difference from the cellular cementum is that it is less mineralized compared to the cellular cementum. Every 6 months, 4 teeth come out into the oral cavity. So that I've explained already. I'm not going to go back and say it again. And even this part we've finished, and we even did a question where by 2.5 years all primary teeth are erupted. So you have to know the chronology of the teeth, both primary and permanent. It's very important. Okay. When it comes to the human permanent dentition, again we have certain tricks. I want to show you something which I learned when I was a student, and it really helped me. So let me show you how I used to remember. So the first tooth to come out is your lower central incisor. Okay, that is at the age of 6 to 7. So we used to remember it as 6 to 7. Okay, like this. Next is 7 to 8. That is your lower lateral incisor, and the same age the upper central comes. So it is 6 to 7, 7 to 8, 7 to 8, 8 to 9. That is your lateral. Okay, and then again come down. So 9 to 10 is your lower canine. All right, and the upper canine comes a bit later. Before that, the first premolar and second premolar comes at the age of 10 to 11, 10 to 12. Okay, and again the same thing with the lower 10 to 12 and 11 to 12, the premolars. Okay, and the first molar, of course, comes out at the same age as your incisor, and the second molar comes around 12 to 13 years in case of upper, and 11 to 13 in case of lower. So lower comes first. Almost all the teeth they come before the upper counterparts of theirs, and the last teeth to erupt are third molars, that is at the age of 17 to 21. So we used to remember it as 6 to 7, 7 to 8, 7 to 8, 8 to 9, then 9 to 10, that is the lower canine, and then go back 10 to 11, 10 to 12, then again come down 10 to 12, 11 to 12, 11 to 13, and 12 to 13. So that's how we would remember the eruption sequence. And we knew already that the first molar and the incisor erupt at the same age, so no need to remember that information. So you can go back home, practice this 6 to 7, 7 to 8, keep doing it a few times. You will never ever forget. And this is the same time when the deciduous teeth sheds. Okay, it's the same age when the deciduous teeth sheds as well. So now you already know when deciduous tooth erupts. When is it going to shed is the same time the permanent teeth is going to erupt. So you will know both of them. Another easy way to remember this is all your permanent first molars and incisor come out within the age of 8 years, between 5 to 8 years. And in the phase 2, that is between 9.5 to 12.5 years, all your canines, premolars and second molars come, and the last teeth to come in phase 3 is your third molars. Okay, so this is again the rules of force for permanent teeth. So at birth, 4 first molars initiate calcification. At 4 years of age, all crowns have initiated calcification, not just the first molars, all of them. By 8 years, all crowns are completed. And by 12 to 13 years of age, all crowns emerge. And by 16 years, all the roots formation is completed. So this is the rules of 4 for the permanent teeth. If the child is still like 5 or 6, you know that everything is primary, and maximum you will have permanent incisors and molars. But as the child is a little bit bigger, say he is around 9 or 10, it gets confusing. So the basic information is important for that reason. So another rules of 6 are there which you can remember for dental development. It is at 6 weeks of in utero life when the whole initiation and calcification begins of all teeth. The first ever tooth. By 6 months of old, when the baby is 6 months, the first tooth emerges into the oral cavity, the first primary tooth. And by the age the child is 6 years, the first permanent tooth comes into the oral cavity. So this is the rules of 6 to remember. So let's see the clinical application, which is very, very, very important. So sometimes when the baby is born, it will have a tooth. Okay, so that is called as natal teeth. Natal is birth, and as soon as the baby is born, he or she has a tooth. So that's called natal teeth. And neonatal teeth is sometimes it is not present at birth, but within the first month after eruption, the tooth comes into the oral cavity, okay, within the 31 days. So that is called as neonatal. Neo is new, natal is of course birth, so in a newborn. So these two are something which you should be aware of. You don't have to do anything because if you remove this, because the baby will have issues in feeding, and it might see, if you can see here, there is some ulceration because probably the child is doing this, with his tongue. So there is ulceration on the soft tissue. So there might be inflammation, fever, the baby is crying. So the mother brings the baby to you, but then until and unless it's a supernumerary tooth, you cannot remove it. You have to just give them instructions on how to manage the situation. Another thing which you see with erupting teeth is called as eruption cyst, which we'll study in detail when you go to oral pathology. I'll teach you. But for now, what you must remember is that it's like a small cystic swelling in relation to an erupting teeth. Again, you don't have to do any treatment. The teeth will erupt on its own. Sometimes there will be bleeding within this cystic swelling, and it takes up a bluish appearance, okay? Sometimes what happens is that the teeth get attached or fused to the bone. That is called as ankylosed teeth. So because of that, the tooth cannot erupt into the oral cavity, and the occlusal surface of this teeth is lower compared to the occlusal surface of its adjacent teeth or the neighboring teeth. So you can see how there is a complete fusion of the roots of this molar here, okay? So the occlusal surface is lower compared to the other, the level of his neighbors, and that's why it's called as submerged teeth, okay? So ankylosis has what led to the submerging of this particular teeth. So other causes of failure of eruption are impactions. I'll tell you what impactions are. Root dilaceration is another important factor because the roots are so dilacerated that it limits the eruption, and it is an indicator of poor prognosis. Until and unless you do something about it, it will not erupt on its own. So this is how normally the roots are, correct? Yeah. Dilaceration, what happens? It's a developmental anomaly basically. So there is acute bend, okay? Acute bend or acute curve along any length of the crown or the root, and most commonly it is in the apical 1/3 of the root. So this is the crown. So what happens to the root is they bend like this, okay? So that is called as dilaceration. There can be some posterior dentoalveolar discrepancy, which could be associated with impaction. Hypothyroidism is another hormonal imbalance where the tooth eruption is delayed for about 2 years or even longer for that matter. But you will see other features of hypothyroidism, and when you do the function, the thyroid function test, you can see that there is a hypofunctioning, okay? And that's when you treat the patient with the drug, and this condition can be corrected. So what is impaction? So whenever there is a failure in the eruption mechanism, the tooth is retained within the jaw itself. It never comes into the oral cavity, and that is called as impaction. So what are some of the commonly impacted teeth? So it is the canines and then the third molars or wisdom teeth. So these are the most commonly impacted teeth. So there's something called as ectopic eruption, which happens, which means that the tooth has erupted in an abnormal position, not in its own position, but in an abnormal position. Sometimes they erupt in the palate, sometimes they erupt in the alveolus, and here you can see that the permanent successors for incisors erupt lingually, but then not so lingually. This is almost like very close to your floor of the mouth. So that is an abnormal position, and that's called as ectopic eruption. As clinicians, when you go to the clinics, you're treating patients, you have to know the eruption and shedding, what is the time of eruption, and what are mixed dentition stages, what are the teeth we see in different age groups of patients. Because a variety of developmental defects that are evident after eruption and shedding can be related to a lot of local and systemic factors, and you should be aware of what is normal to differentiate it from what is abnormal. That is the reason you're studying all the normal structures, normal histology, normal anatomy, because next year you will study what is abnormal. I think we did both eruption and shedding. It'll be too much to summarize both. So I want you all, the takeaway message from this entire thing, I want you all to remember the eruption date and the shedding date of the primary teeth. The shedding date of primary teeth is the eruption date of your permanent teeth, correct? So as long as you memorize this table, I'll be very happy. You might have a little trouble here because there is a range. Memorize the exact age, it's okay. But you have to remember that there could be a delay of 6 months to 1 year, which is acceptable. All right, so that is why they give a range of the age when there is eruption and shedding, and they don't give an exact age.